Hi, this is my second lecture for the Sarawak Pediatric Urology Update, and the title is Urodynamic Studies in Children. It's a complicated topic, so I try to make it easy, and I will illustrate with some case studies. Urodynamic is the evaluation of function and dysfunction of the bladder, sphincters, and by definition, it also includes the upper tract by doing the Whittaker's test via nephrostomy. Of course, we seldom do this test nowadays unless the patient already have a nephrostomy or we don't have access to radioisotope scans. It is a wrong perception that urodynamic study will answer all questions. It's a magic test. Or urodynamic is very difficult, especially if you're going for a professional exam. But urodynamic is invasive and therefore not very popular. In this lecture, I try to talk about the concepts of urodynamics, the hardware that we use, and the catheters that we have used over the years. Previously, they were used to be water-filled. Now they are air-charged. If you look at the congenital abnormalities, in fact, the biggest by far is the central nervous system. So the child will be born with a neuropathic bladder, and therefore urodynamic is a very important part of the practice of pediatric urology. The commonest cause of a neuropathic bladder will be some kind of spina bifida. And in fact, we started in the main hospital in Kuala Lumpur in 1991, a spina bifida clinic with the pediatric neurologist and of course with the pediatric nephrologist. Other causes of bladder dysfunction are posterior valve, dysfunction voiding, various kinds of problems with the spinal cord, and of course in developing countries, tuberculosis, transverse myelitis are still important. We have the occasional bladder tumor. We still have a lot of trauma and our occasional vascular malformation of the spinal cord. Can you die at urodynamics? Well, if the patient have a high spinal lesion during the manipulation of the urethra and the bladder, they can have an autonomic hypertension, severe hypertension, and then now we have a stroke. And some patients, especially Caucasian patients, they may be allergic to latex and they can have an anaphylactic shock when you introduce a rubber catheter. What are the precautions to do for urodynamic studies? The patient should have some form of sedation, not chemical sedation, sort of reassurance by the carer or by the family members. If the patient has gross reflux, then a lot of the fluid that's used will go up the ureter into the kidney, so the urodynamic study will not of the bladder function will not be accurate. We have to do urodynamics on top of the normal bladder volume of the child, but we have to empty the bladder at the end. And of course, introducing catheters can introduce infection, and often we have to give them a dose of antibiotic prophylaxis. I used to give gentamicin. The main type of urodynamics done in most hospitals would be a feeling cystometry, which we can do at first contact with the patient, and often in developing countries, it is 3 or 4 years old. Or if it is antenatal diagnosis, we can do it when the child is about 3 months old. Of course, we have to use smaller catheter size, or sometimes we have to put a super big catheter. And thereafter, we have to do it every now and then, especially if the patient is going for surgery. So the commonest cause of a neuropathic bladder would be some kind of spina bifida, and unfortunately, we still have plenty of spinal problems, catheter cord in developing countries, and apparently this is easily preventable if you take enough folic acid during the pregnancy. In fact, there was a proposal by the previous chief of pediatrics in Malaysia to add folic acid to the rice that we take, just as much as we add the iodine to the salt. So this is a diagram of the nerve supply to the bladder. There's parasympathetic, there's sympathetic, and there's pituitary nerve supply. And it goes to the spinal cord and goes to the brain. But injury or disease often affects different parts and sometimes maybe incomplete lesions. So if you follow up these patients with neuropathic bladders, They can come as normal. Later on, they can become abnormal. So there's often progression of the neuropathy of the bladder. So you may have to repeat the urodynamics now and then. Now I show you some hardware that I've been used to. This was the thermal printer urodynamics that I used in the main hospital in Kuala Lumpur when I was working there in 1984. Subsequently, we used a very simple urodynamic setup for many years. And when I came back to Sarawak, I used again the basic set of urodynamics from Dentec, whereby we fill the bladder with 2 catheters, either per urethra or through the suprapubic introduction of 2 small catheters and another catheter in the rectum. So this is the basic setup of urodynamics. Now, currently, this is the newer setup at the local government hospital, and it introduces 2 catheters. The catheter into the bladder actually is a double lumen, and 1 catheter is into the rectum. And nowadays, most of the instruments come as air charge instead of water charge. And of course, again, there's a problem with sedation to get the mother and the carrier to be in place so that the child is cooperative. And the problem with the air charge catheters is that the transducers are very expensive. So there's a cost concern compared to the older forms of urodynamics. This is the urodynamic in another center in my town. Again, this doesn't have a video to record the findings. So this is the classical setup whereby the bladder is filled by infusion. There's a transducer to record the pressures in the bladder and in the rectum. It's very important to use room temperature. It's very important that the system do not have any air bubbles, and it must be zero to the symphysis pubis. The volume to fill into the bladder depends on the age of the patient. I use this formula, age plus 2 in ounce, so that you don't overfill the bladder nor underfill the bladder. So this is a normal urodynamics, where the pressure, the bladder pressure, the detrusor bladder pressure do not rise as they fill until the patient has a sensation to void. And when the patient voids with a good urine flow, then there is a rise in bladder pressure. This is the voiding phase, where the patient has voiding and the patient voids with a normal voiding pressure, depending on the age of the patient. If the patient has a high voiding pressure and a low flow, it means that the patient has obstruction of some sort. And the voiding pressure, again, depending on the gender of the child. So it should be less than 55, and the girls is about 30. They have a shorter urethra. Now, obviously, high pressure means it's obstruction. Unfortunately, of course, there's always an equivocal band of voiding pressure. This patient has got involuntary bladder contractions. This is called hyperreflexia or detrusor instability, but he always returns back to the baseline. This is another patient. Not only do they have involuntary contractions, there's also very poor compliance. And this is the kind of patient that have got renal impairment. Eventually, they're bilateral hydronephrosis, and if you do nothing, they got renal failure. So that is an unsafe bladder. Okay, detrusor hyperreflexia, poor compliance. If the patient has got a flat filling curve, likely they are going to be safe. So the low pressure is safe for upper tracts. High pressure can cause hydronephrosis and renal failure. And this figure, this magic figure of 40 centimeter was introduced by McGuire in 1981. Unfortunately, again, there is an intermediate group. And of course, the bladder pressures can change over time. So more than 40 centimeters intravesical pressure, either during voiding or by abdominal pressure or by detrusor or at the detrusor leak point pressure, this is an indication that the patient can have renal impairment. If the patient has got a low pressure bladder, however, and they have a good sphincter, then the patient can safely empty the bladder to avoid over-distension using clean intermittent self-catheter or clean intermittent catheter by a parent. If the patient has a low pressure and a weak sphincter, then the patient can have diapers until we're able to introduce, the child can use an artificial urinary sphincter. Now, we know that urodynamic studies are useful in selected cases, especially in children with voiding problems, whereby we can actually simultaneously record the bladder pressure, urine flow rate, and looking at the voiding, looking at the urethra. At the same time, we look upwards, look at the ureter and the bladder. And also at the same time, we can record the sphincter EMG activity and also look at the urethral pressure profile. So this is a very complete study. And this is again the similar setup, but there is an extra unit whereby we monitor the filling, and this filling, of course, is using radio contrast. So this is a setup in a major hospital in Kuala Lumpur. Basically, they use a C-arm with a radiolucent table to do the recording. And this was when I was in the Western General Hospital many years ago, whereby the urodynamics at that time was done by a radiographer, and every Friday, all of us will sit down and with the incontinence nurse to look at all the urodynamic studies that was done in Kuching. I understand that the local university will be able to perform this form of video urodynamics for selected patients. When a patient is voiding, there should not be any activity of the sphincter. So if there is persistent activity during voiding, there's called detrusor sphincter dyssynergia. Now, all this requires the insertion of a catheter in the urethra or suprapubic and the rectum. So this is invasive. What about doing urodynamics with no catheters? Is there such a thing? Well, when people talk about non-invasive urodynamics, what they meant is that they assess the function of the urinary tract by looking at other things, which consists of the history, which consists of the examination, which consists of laboratory investigations, whether there's any increase in creatinine, doing the ultrasound to look at the kidney, any hydronephrosis, any hydroureter, look at the bladder wall thickness, the bladder volume post-maturation, and I think that the only truly non-invasive is doing the uroflowmetry. Of course, we can also, in addition to ultrasound, we can do a radioisotope scan to see the function and the drainage of the upper tract. So ultrasound is the most useful non-invasive urodynamic test, looking for hydronephrosis and followed up the ureter and looking at the bladder wall thickness pre and post maturation. So this is the uroflowmeter. This should be in a convenient place where the child is comfortable with privacy and not in the office itself. So if they have insufficient privacy, then they may have a forced uroflowmetry. And in children, most of the flow meters are meant for adults. So if they don't have enough, if they don't have good foot support, for example, this slide is courtesy of Professor Stephen Young in Taipei. So this shows that a girl who has got uroflow with proper foot support, with relaxation, and another uroflow where the child has severe constipation, and after the constipation has been managed, the urine flow returns to normal. So that these are different types of flow rate. So this is non-invasive urodynamics, the first part of urodynamics, where the child just passes urine into a flow meter, and from the flow pattern you can come to some kind of deduction as to the underlying abnormality. Now, the last few years, the urodynamic community have recognized that there's a thing called impaired detrusor contractility. In other words, if the patient doesn't pass urine well, if the patient has a low flow, sometimes it's due to low pressure, low bladder pressure, not an obstruction, not obstruction. So this is low flow and low bladder pressure. So this is a big group of patients as well. And sometimes these patients, they can empty their bladder, but if you look at the uroflow, they empty the bladder by abdominal straining. So this is another group of patients whereby they are not able to empty the bladder well because there's incomplete relaxation of the sphincteric mechanism. So this is called dysfunctional voiding according to the International Children's Continence Society. So in dysfunctional voiding, the bladder contracts, but the sphincter does not relax. There are various ways of treating this. Quite often it's associated with bladder bowel dysfunction. So we can treat all the associated factors giving rise to dysfunctional voiding, including the treatment of any infection, treatment of we can sometimes use alpha blockers, we can use biofeedback and various strategies to treat the chronic constipation. Now, this is from a previous collection of material, and this is a patient who had a spinal insult. And in those days, we do intravenous urogram on presentation, and this patient shows a normal upper tract. We leave the patient for 2 years, and the patient has got bilateral hydronephrosis and a contracted bladder. So the idea of treatment is to prevent this from happening, because if we leave this for another few years or a few more months, if they have got severe infection, they can go renal failure. So the idea is to preserve the upper tract, preserve urinary function before it happens. This is a patient referred to me when I was in the hospital in Kuala Lumpur, asking me to consider cystoplasty because the patient has got persistent creatinine of 400 and there's bilateral hydronephrosis. The referring doctor did not bother to mention that the patient also has severe bed sores with osteomyelitis. So this is extremely bad management, poor management. Patients can die of urinary tract infection, die of kidney failure, and die of bed sores with infection. So the aim of treatment is to avoid all this. So in the beginning, we can manage the bladder with anticholinergics to reduce the high pressure. Nowadays, you can use Botox. Of course, it's important to manage the constipation. And finally, of course, we can do surgery onto the bladder. Patients managed early with anticholinergics, usually oxybutynin, who have less problems with upper tract deterioration. What are the indications for cystoplasty? If we know that it's a high pressure bladder, they are going to have hydronephrosis, and if they have recurrent UTIs, or if the patient already have renal impairment and they're going for a transplant, then of course we have to fix the bladder before they go on to kidney transplantation. In the study that I did when I was working in Kuala Lumpur, quite a lot of the patients required cystoplasty. And of course, if the uretrovesical junction is also obstructed by the hypertrophic bladder, we often have to reimplant the ureters as well. So this is one such star patient of mine. She was operated as a child by the neurosurgeon, as an infant by the neurosurgeon for spinal bifida, and sort of lost to follow up. Either the doctor lost her, or she lost the doctor, and she was referred to me only at the age of 12 when there was already gross hydronephrosis, trabecular bladder, fur-tree bladder, and we did clamp cystoplasty. I did bilateral implantation, creatinine normalized, and the patient is well now after 30 years. So this is the kind of management we try to do. This is called clamp cystoplasty. Basically, we divide the bladder as in the clamp, and we put the small intestine to augment the bladder and try to bring the pressure down as much as possible. So this is before cystoplasty, and this is after cystoplasty. It's not exactly baseline, but the pressures are much lower. Of course, cystoplasty means we take a segment of the intestine, and the intestine can have complications following surgery. Intestines produces mucus, so it's not a harmless operation. We try not to do it in very small children. The mean age of this group of children was 13 years. And doing the cystoplasty will probably stop the progression of the upper tract degeneration, but it does not reverse the renal impairment that has already happened. So that's why the importance of urodynamics to pick up these unsafe bladders and to intervene early before they actually got renal impairment. So if the patient has got poor compliance, then we will have to consider doing cystoplasty. If the patient is unable to do cystoplasty, then we can have alternative intervention like putting the patient on a catheter to have night drainage, doing more regular clean intermittent catheterization, giving the patient Botox into the bladder. But of course, when you give Botox, the patient must be ready to do intermittent catheterization. And finally, of course, we can do surgery onto the bladder, either a supravesical diversion with the appendix, or we can do a clamp cystoplasty. So I hope that you have some ideas from my urodynamics, make simple. Thank you very much for your attention.